Okay, time to talk about Meralgia Parasethetica. So this is a question that comes up in our OBGYN realm. So it can be caused by pregnancy, also by other things like diabetes or straight up injury, tight clothes. And how you get this is compression of the lateral femoral cutaneous nerve at the inguinal ligament. And so you might see this in pregnant women in their third trimester, just because they have a gravid abdomen, heavy abdomen. So that's why that would happen. In a case like this, you might get described sensation of pain and numbness of the lateral thigh. And importantly, you shouldn't get any motor weakness or deficits. And this is a clinical diagnosis, so you don't need any imaging. The management's it's mainly conservative. You don't need to, you want to avoid wearing tight clothing if this is appropriate weight loss, but otherwise it's self-limited in pregnancy. So you don't really need to do anything if this is related to pregnancy. It should go away after you give birth. And if that doesn't work, then there's gabapentin or nerve block. And something to note, which is what I did, is kind of confuse this with sciatica. But with sciatica, you might experience some weakness, and you would have a positive straight leg raise test if this was a case of sciatica. You wouldn't necessarily have a positive straight leg raise test with this condition. Okay, next, von Hippel-Lindau disease. Okay, let's talk about etiology. You get this by a mutation in the VHL tumor suppressor gene, which causes some abnormal growth of the blood vessels. It's an autosomal dominant disease, so you might see some family history in people who have von Hippel-Lindau disease. It tends to affect people in early adulthood, but you can manifest it at various ages. Clinical features, hemangioblastomas of both the eye and the brain can happen. You can also get some pheochromocytomas and renal cell carcinoma. But there's a bunch of other things that can also show up. It's multisystemic, but these are the most common ones. In terms of diagnosis, you would want to confirm this with some genetic testing. And overall management is to have continual surveillance for other cancers or other hemangioblastomas, like checking out the eye and the brain, and just monitoring for that. Okay, heart block, atrioventricular block. This is a topic I'm not the best in, and I tend to get these answers wrong. So let's talk about it. Epidemiology. So you may see this in athletes because of their high vagal tone. So you could see a first degree or Mobitz type 1, but this is overall benign. Some features of it are, so there's differences depending on what degree you have. In the first degree and Mobitz 1, typically asymptomatic. And if you have Mobitz 2 and the third degree, you might feel fatigued, lightheaded, or also fainting. And you diagnose this by ECGs, which you can see here for the different types. So the type 1, you'll see that you get the P intervals between each P become longer. I don't know if that's easy to tell in this. 1, 2, 3, 4, about 4 boxes. Yeah. and then they tend to get a little bit longer as each one goes on, and then gets dropped. The QRS gets dropped. And as opposed to Mobitz type 2, these P intervals are pretty much the same, and then a QRS gets dropped. So that's the difference between that. And I did see a mnemonic or something like that to help remember type 1, which is also called Wenke Bach. The longer drop, then you have a Wenke Bach. So that's for the Mobitz type 1. So how you want to manage this is if it's a first degree or the Mobitz 1, you can just observe them. But if you have a Mobitz type 2 or a third degree, then you want to consider doing a pacemaker. So the differences between type 1 and type 2 kind of differentiate this management point. So Mobitz type 1 is relatively benign, and type 2 you'll require intervention. All right, let's talk a little about sepsis. I got a question wrong on this because of updated criteria, and I was thinking about it in the old way as opposed to the new way. So sepsis occurs from infection, and the definition of it is life-threatening organ dysfunction caused by dysregulated host response to infection. And so the old way was that you might want to suspect sepsis is search criteria seen here. But there's been new criteria that's been updated by some sepsis convention. This was the search criteria was created in the 1990s, and this was more the Acute SOFA was more recently. So the finer points of Acute SOFA are that you would get a point if you had systolic blood pressure less than 100 or a respiratory rate of greater than 20. Oh, sorry, yeah. No, that should be breath. 22 per minute, and an altered mental status. So this is what tripped me up, altered mental status. That was not even at all on the search criteria. So altered mental status can be caused by a whole bunch of other stuff. But nevertheless, this QSOFA, why they have this on here is that it's associated with decline, but it does not define sepsis. So just because you have a positive QSOFA, you meet all the criteria, doesn't mean that you necessarily have sepsis and it's infection. It could be a bunch of other stuff. It's just that the research has showed that you have a like 2 to 3 times increased risk of death or a long ICU stay if you qualify for this criteria. So yeah, just keep that in mind. This is started off as a research tool, but I've seen more and more that hospitals are adopting this. And if you have any of these, then you should start to enact your sepsis protocol and see if there's any infection going on. So you want to start antibiotics within the first hour, but you also want to get blood cultures before you start the antibiotics, and you want to do fluid resuscitation within the first 3 hours. So that's some of the steps you do if you are suspecting sepsis. But again, one key point that threw me off was this altered mental status. So don't let that trip you up, and to think about it if if you meet some of the other criteria. And just be aware you might not have fever. This is what also tripped me up, is that fever is not on this criteria, which I typically associate with infection. And so when I didn't see a fever, but also menses and all these other stuff, I wasn't necessarily thinking about sepsis right away, given the history of a whole bunch of other comorbid conditions. But keep that in mind. Okay, next, fibromyalgia. All right, let's look at the epidemiology. Now, who are you envisioning in your mind that might have fibromyalgia? If you guessed young to middle-aged women, then you are right. And now clinical features. What are some of the things you're thinking about for fibromyalgia? Well, I hope you're thinking about pain in various parts of your body, feeling very fatigued with cognitive/mood changes. Oh, I didn't put anything there. Okay. And then in terms of management, what are we thinking here? So the first ones are conservative management. You want to focus on exercise and having a good sleep schedule. And if those don't work, then you want to try tricyclic antidepressants, namely amitriptyline. But if that doesn't work, then you can try some SNRIs or pregabalin. And if all of those don't work, you should probably also consider doing CBT therapy on top of that, and also maybe referring them to pain management. Okay, now something to think about, and that I got wrong in this, was choosing a management that involves NSAIDs or glucocorticoids. They do not help in this situation because this is not an inflammatory condition. So don't choose that for your management. Next topic is acute mesenteric ischemia. Now, what do you think about the etiology or the pathophysiology when you think about mesenteric ischemia? Well, as its name implies, it has to do with a thrombus or something obstructing blood flow. So this can result from a cardiac embolus or a thrombus within the artery itself, or a situation where you have shock or vasoconstriction in your mesenteric arteries. Now, who are the people getting this? Well, people who have risk factors for, they have atherosclerosis, there's a source for embolus like an AFib. This is a really key thing to note if they're just in generally hypercoagulable, and you'll commonly see this in the elderly. Now, what are some features for acute mesenteric ischemia? Well, that's going to be, you're going to think about an acute onset, severe abdominal pain that might worsen with eating, nausea, and vomiting. Now, some of the lab findings, you might see leukocytosis and elevated amylase and metabolic acidosis. Some of the signs for metabolic acidosis you might see are a high lactate level, or more commonly a low bicarb. Now, how are you going to diagnose it? What kind of test will you do? You're going to do a CT angiography. And once you diagnose it, the management will be surgery. So you can do an open embolectomy, or you can do some cool endovascular things and remove the thrombus that way. So important to remember, if you have a situation where you have AFib and a patient has AFib and like a serum chemistry that looks like they have metabolic acidosis, your bicarb's doing something weird, it's low, and they have abdominal pain, that should give you a hint that you want to think about acute mesenteric ischemia. I feel like I've gotten a lot of questions wrong and thinking it's something else because I didn't look at the other things that they were hinting at, like the AFib or the chemistries that were telling you acidosis. Okay, next is cardiac myxoma. So what is this? It's just a cardiac tumor, and they're typically benign. And then they're one of the more common ones, and they're primarily located in the left atrium. Now, what are some of the features that are associated with the myxoma? Well, I hope you're thinking about constitutional symptoms like fever, weight loss. You might even see heart failure-like symptoms like dyspnea, feeling lightheaded, if this tumor is obstructing. You also will get associated embolization into the systemic circulation. That can end up causing stroke, limb ischemia, mesenteric ischemia, and all sorts of bad stuff. How do you diagnose it? You want to get an echo done. And then management will be surgical removal. Okay, something that, so the echo, what it's going to say is, it'll tell you that there's a mass there. And one thing I got wrong was thinking about infective endocarditis, which is also associated with fevers, and myxomas are as well. So I kind of got those confused. But echo should clarify that in saying that this is a mass. And if it was endocarditis, it might describe something like vegetation.